Associates Group. Take it away, guys.
Okay, hello everybody, and welcome.
Hi.
So we're here today to talk to you about the pending transition to PDPM, and particularly about Section D of the MDS, which deals with mood and behaviors, which have an impact on reimbursement, and we're going to talk a little bit about that. First, I'm going to give you a little bit of an overview of PDPM. I assume many of you have been to sessions in your facilities to orient you to what PDPM is all about, but just in case you haven't, I'll give you an overview of it. If you have been to sessions, you know, the adult learner needs to hear things 7 times before it kicks in. So if you've only heard it 5 or 6 times before, this will be the 6th or 7th, and hopefully it'll help you really get it. So let's go on to the next slide, and this is our objectives for the presentation. And basically we're going to talk about the changes being implemented. It's October 1st. There's no transition time. It's going to be like, it starts right then, October 1st. There's no phase in. We're going to talk about the importance of ICD-10 coding and common pitfalls. And we're going to talk, actually, we're not going to be talking about section ICD-10. We're going to be talking about Section D. And we're going to talk about the processes that can be put in place to ensure you have accurate coding of Section D so that you accurately capture the patient characteristics that will drive your PDPM category. So next slide, please. So the PDPM is a new case mix classification system for classifying nursing facility residents, and it becomes the payment mechanism for Part A stay under Medicare. Now, only under traditional Part A stay. It does not cover managed Medicare, and doesn't cover your commercial plans, which are still reimbursed under their contracts. Although some commercial payers may elect to use PDPM as the reimbursement category. It depends on whether or not you contract for that. But let's just say effective October 1st, it's really replacing RUG 4 for your traditional Medicare patients. That may change as time progresses. The system only pays for patient characteristics such as the diagnosis and level of functioning, rather than the amount of services that are being provided. Payments are based on objective patient characteristics that are predictive of service needs, and it includes refinements to the previous RCS-1 model that was circulated last year but never implemented. When it goes into effect, it's going to drastically change how skilled nursing facilities treat medical Part A residents, Medicare Part A residents, particularly in the delivery of therapy. So as I said, it separates the amount of therapy from the payment by no longer relying on the minutes of therapy provided to a resident to classify that resident into a payment category. And frankly, under RUG 4, that wasn't the case unless you were in a rehab category. The situation under RUG 4 was the highest reimbursement categories were in the rehab category. So regardless of whether a person was in primarily for medical issues or kind of social determinant type of issues, like not having a safe place to go to or whatever, we always look to try to get them into therapy, because then the more therapy minutes we got, the higher the reimbursement rate goes. That's no longer the case. You can't do that with PDPM. In PDPM, there's 5 individual components, each with its own discrete case mix adjustment that classifies each resident into an appropriate category. And these are physical therapy, occupational therapy, speech-language pathology, nursing, and non-therapy ancillaries based on residents' clinical and functional characteristics. It also incorporates a variable per diem payment adjustment for the PT, OT, and non-therapy ancillary components, which results in a decreasing daily payment as a resident's stay progresses. So the first couple of days is the highest reimbursement, and then it tapers down beginning on day 20. So what they're doing is incentivizing us to get residents out as quickly as possible. But we're also, expected to have good outcomes. It also, this is a nice thing, it reduces the number of PPS assessments to just a 5-day scheduled PPS assessment, a discharge assessment, and a new interim payment assessment, IPA, which is very similar to what we used to call significant change. It's not exactly the same, but for those of you who are not being sophisticated with MDSs, just think of it as a sig change. But the nice thing is, there's just that one, 5-day assessment, actually done on day 3, with I think a assessment reference date can be anywhere from day 1 to day 8, but you don't have to do the 14-day, the 30-day, and so forth. Yeah, exactly. So that now, of course, on the long-term side, the over-assessments are still unchanged. Skilled therapy services are still reimbursed by Medicare under PDPM. So if you hear people say there's no more therapy in nursing homes, that's not true. What it is the facility is being paid for the amount of therapy that residents of that diagnosis and those physical characteristics and behavioral characteristics typically need. It doesn't change the care needs of the resident. Those are should be the primary driver of care decisions. You always want to do what's best for the patient clinically, but the amount of therapy the patient receives is documented in the discharge MDS assessment. So for facilities that think, well, we're not being paid by the minute anymore, so we really don't have to give any therapy and just try to get the outcomes as best we can, they're going to still be looking at how much therapy patients actually do. They're not going to require a certain amount, but we don't know yet what criteria the auditors are going to be using for what's an appropriate amount of therapy. So here's a graphic that shows under RUG 4 on the left, the categorization of the patient was based on predicting services needed based on the services provided during that initial period. So when I was the director of nursing back when PPS started, well, we had this joke that we'd put a tent in the parking lot, so when the ambulance pulled up, we would start doing physical therapy, because the more minutes you got in those first couple of days, the higher the level was. Now, that was only partially true. I mean, we literally did start giving 7 days a week therapy so that, we could make sure that the first couple of days, if they came in on a Friday, they were getting therapy on Saturday and Sunday, so we could make sure they had those minutes. Now, that's not going to be such an important thing, because the categorization now on the right is based on the anticipated utilization of services typically needed by patients with the same diagnosis and functional level. Now, the word typical is important because some patients may need more and some patients may need less, but when reimbursements develop this way based on research, they come up with an average. As I said, PDPM removes therapy minutes as a determinant of payment. The current RUG system allows provider to receive payment for the therapy they decide to provide. The new PDPM system is based on clinical characteristics that determine the payment, not the amount of services provided. Payment will flow from how the patient presents rather than how much service is provided. So I think I've said that about 5 different ways, so I hope it sinks in. The PDPM classification methodology utilizes a combination of 6 payment components to derive the payment. 5 of the components are case mix adjusted. One is just kind of like the room and board fixed case mix adjusted component. And here they are. There's 25 different levels of nursing. There's 16 levels of physical therapy, 16 levels of occupational therapy, 12 levels of speech language, and 6 levels of non-therapy ancillaries. The important thing here is for every patient, every one of these categories becomes important, because what happens is the case mix and the dollar amount at each of these levels goes into what the total payment is going to be for the resident. That wasn't the case in RUG 4. Remember, in RUG 4, if you had someone in a rehab category, then the payment was based just on the rehab level. If you had someone in a clinically complex, it was just based basically on what now is the nursing level. Now, every one of these is going to contribute to what the reimbursement is. The payment for each component is calculated by multiplying the case mix index that corresponds to the patient's CMG by the wage adjustment. And then the base payment rate, and then the specific day and the variable per diem. As I said, the rate drops over time. So let me just show you, here's an example. You see how you have a resident comes in, let's say it's in an urban environment here in New York City. There's a nursing case mix that's based on the nursing assessments that are done on this MDS, the non-therapy ancillary case mix, the PT case mix, the OT case mix, speech-language pathology case mix, and the non-case mix, room and ward. All those get added up to come up to the total rate. So you see, it's not just one category that drives the reimbursement rate. So to determine what this case mix is going to be, determine the clinical reason for the person's stay, and that's item I-8000 on the MDS. That's the ICD-10 code. And we're having a separate webinar on ICD-10 coding. And at the end of the slide, you'll see you can get a 50% discount on that webinar if you're interested. We also look at the resident's functional status based on self-performance of transfers, eating, and toileting. And that's section GG of the MDS. Not to be confused with section G. There's similar questions. They're answered completely differently. Again, that's a whole nother webinar we can go into. And then what Gene's going to be talking about is the cognitive status, which capitalizes on the cognitive functional scale, which is based on the responses from the brief interview for mental status, the BIMS, and the cognitive performance scale, CPS. This just talks about the different categorizations of the ICD-10 coding, forming the basis for reimbursement in different categories. The functional assessment, the section GG, is the same questions that are being asked in long-term care acute hospitals, skilled nursing facilities, and also in home care. That's why they give you a separate section GG and not just rely on the traditional section G. Let's talk about cognitive scoring. Under PDPM, just as under Rug 4, a patient's cognitive status is assessed using either the BIMS or the cognitive performance scale. This is important. In case where the BIMS is not or cannot be completed, a staff assessment for mental status is completed. If you don't do that, you get an absolute 0. And my slides are not progressing here. There we go. The new PDPM cognitive measure is based on the cognitive function scale, which combines scores from the BIMS and CPS into one scale that can be used to compare cognitive function across all patients. Screening of depression in section D of the MDS creates an N split with a higher case mix and higher reimbursement for the following nursing categories: serious medical conditions such as comatose, septicemia, respiratory therapy, serious medical conditions such as patients with radiation therapy or dialysis, and conditions requiring complex medical care such as pneumonia, surgical wounds, and burns. So what we're saying here is section D is important in PDPM if you have one of these diagnostic categories on the rest of the MDS. Then capturing the screen for depression on section D can give you what they call an N split, which means it's a decision point. If you have that category with depression, there's a certain case mix and a rate, and if you have that category without depression, there's a lower case mix and a rate. So these are the three areas where section D becomes important from a reimbursement point of view. Now, from a clinical point of view, it's important for every patient. But in terms of reimbursement, it's only so we're only talking about Medicare Part A patients, and we're only talking about these three conditions where it's going to make a difference in reimbursement. I say that because some people will lead you to believe that PDPM, you're made or broken on the basis of section D. It's important, it's a component of it, but it's not the be-all and end-all. Okay, I'm going to, this is just some information about what the non-therapy ancillaries are. Those are all diagnostic categories that will give you a significant increase in reimbursement. But I don't want to take up Jean's time, and I'm going to turn the slides over to her to talk about Section D.
I want to keep doing it.
Oh, sure.
Okay. Hi, everyone.
Give me Vanna Wait.
Joe's going to advance the slides for me. So I'm happy to be here and talk about this. We've been actually training on Section D in the nursing homes where I consult for years, because it did affect the, in the RUG system, it did affect the clinically complex group of patients that are part of long-term care typically. But now under PDPM, it becomes more important in terms of reimbursement for the subacute as well. And you've got that crucial one-time only kind of chance of assessment. For most patients, it's going to be that first assessment that determines it. So being up on getting the most accurate capture you possibly can is really the goal. And there are certain set of errors that people consistently make when they're doing the assessment that I'm going to be going over. And there's a couple of things to really keep in mind to understand it. So the first issue that we need to be clear on is that the PHQ-9, which is used in a lot of settings, which is essentially the questions of Section D, the staff assessment actually has 10 questions. They don't result in a diagnosis. We're not diagnosing depression here. And that's a really important concept for people who are using Section D to keep in mind. This is a data collection tool about potential clinical issues. It's not a diagnostic test. It's a screening, and screening does not mean diagnosis. It means maybe, not definitely. So it's, in most nursing homes where I consult, it's social workers, mental health professionals who are completing Section D. But it's interesting to note that when it was developed, it was not developed for mental health professionals to necessarily be required to give this instrument. It was sort of thought that anybody who knows the patient well or who the patient is comfortable with, it would be a good person to ask these questions. The reason I say sometimes mental health professionals actually find it more difficult is it's sometimes hard for them to stay in the screening mode, and they slip into the diagnostic mode, and they're actually kind of putting themselves at a disadvantage because it's important to screen accurately. All right, next. Okay, the reason it's so important to screen accurately is that we're going to have lots of false negatives. Now, in any test you take, whether you go for any medical test you've ever taken in your life, you know, a chest x-ray because maybe you have pneumonia, when the test says you don't have the illness, but you actually do have it, that's the false negative. The false positive is when the x-ray shows that you've got something that turns out you don't. The true negative is when the test shows you don't have it and you actually don't, and the true positive is the test says you do have it and you do. Next. So the way Section D, or the PHQ-9, was constructed was to virtually eliminate false negatives. We never, ever, ever want to miss anyone who actually does have a mood disorder. Every single person with a mood disorder should be captured. But that means that we're going to tolerate a high number of false positives, meaning a lot of people will be captured on the screening that actually turn out not to have a mood issue. And it's interesting to note, I'd like to refer to it as Section D indicators, because it on some level amuses me that that section was named the mood section, and the result of the mood section screening is a depression score, as if depression is the only mood anybody ever has. So it's better to simply think of it as Section D indicators. the way that we sort it out and decide who actually does need a care plan and for what mood disorder, that takes diagnostic testing. Okay, next. All right, so here's the list of the questions, and I'm sure many of you are familiar with it. One of the points I want to make is that another little thing about the MDS mood section, when it was constructed, it was normed in the original early research. It was normed primarily out in the Midwest. And Midwest people are very polite. Hi, everybody from the Midwest who's listening. and the concept was that it was sort of a gentler way to ask the question, to say, have you been bothered by? Over the last 2 weeks, have you been bothered by? But as a New Yorker, my first thought when I heard, have I been bothered by, was, I have a limp. I'm not bothered by it, but I have it. So what are you asking me? Is it annoying me, or am I experiencing it? And the word bothered by is supposed to be, are you experiencing this? So keep that in mind with your population in terms of when you're asking these questions. And now, if you sort of cast your eye down this list and you think of people who don't have mood disorders necessarily, there may be other reasons somebody has little interest and pleasure in doing things, or might be feeling down, or having trouble with sleep, or appetite, or energy. When you feel bad about yourself and feel like a failure, that really does indicate a cognitive component of depression. Trouble concentrating can be from a lot of things. Moving slowly or quickly may be from various factors, not just mood. Thinking you would be better off dead or hurting himself, that's going to indicate a mood issue in all likelihood. And short-tempered, easily annoyed, that it's interesting because with depression in particular, there is a gender difference typically, and I'm just talking in gross numbers typically, not everybody, but often in private practice, for instance, patients will come into my practice, and if they're female, they tend more likely to present their depression as sadness. But when a man comes into my private practice with depression, he more frequently will present that depression as anger and irritability. And in the therapeutic process, I'm always fascinated to see that as I work through that woman's sadness, I get to her anger. And as I work through that man's anger, I get to his sadness. So anger and sadness, think of them as the heads and tails of the same coin. So that nasty, annoying, short-tempered, easily triggered, yelling, cursing guy you might have on your unit, he might be depressed. So just keep that in mind as a possibility. All right, so these are the things we're looking for. We're looking for all the different depression and dysthymia disorders, and there's a few, and I won't go into all of that. And the questions that are loading on depression are as listed: little interest in pleasure, hopeless, helpless. That's the cognitive component of depression, is hopeless, helpless, worthless, guilty. My life is awful. I feel hopeless about it getting better. I feel helpless about making it better. It's my fault it's this way, and I feel worthless about it. That's real serious cognitive content of depression. You also get a biological sign of depression, of serious depression, is an early morning awakening. People go to sleep fine, and then they pop awake in the middle of the night, and they can't get back to sleep. Popping awake is fine. People get up and use the bathroom, whatever, but they go back to sleep. People who've had only 4 hours of sleep and then can't get back to sleep, that's a depression indicator. For instance, just to stick on sleep, because it's the most important prodromal sign of an impending episode of mental illness, is a shift in sleep pattern. People who are getting into a manic episode, no sleep in a 24-hour period with still having high energy over a couple of days, you start thinking about mania. Difficulty falling asleep, you consider anxiety. Difficulty staying asleep, you consider depression. Okay, so we've got all the bipolar, mania, cyclothymia type of issues, the anxiety and panic and PTSD, and by the way, and this should be another webinar, Joe.
Okay.
We've got to do trauma-informed care,
Right.
because that regulation goes into effect in November, I believe, unless they've decided to postpone it.
Not likely.
Not likely. Okay. I think some people are hoping for that.
Yeah.
But all staff that come in contact with patients must have an understanding of trauma-informed care, or else that's by an FTAB. It's a regulation that you don't meet. So that has to do with the PTSD. Adjustment disorders are what people without serious mental illness go through when something bad happens. So you're in a car accident and you have a broken leg and now you need rehab. You may have some anxiety, some depression, difficulty sleeping, you might be irritable, and it doesn't indicate that you have a lifelong serious mental illness. It's just your adjustment to the situation. Then we have psychotic disorders that have mood aspects. So that screening doesn't just pick up on depression. It can pick up on all of this stuff, all of these different psychiatric and psychological disorders. Next slide. Okay, so then there are all the things that might pick up too that's not technically a psychological issue. For instance, there are medication side effects that might make you too sleepy. There can be frontal lobe damage, which results in issues of control, disorders of control, of impulse control. There are attention deficit and hyperactivity, which you might see even in older adults, fidgety, restless, poor concentration. People may have something called body dysmorphic eating disorder. That is a psychological and psychiatric disorder, but it's not one of the mood disorders that we're necessarily screening for in the mood section, but we may pick it up. And of course, dementia, because when you think about someone in a moderate to somewhat advanced state of dementia, perhaps sitting in his wheelchair, looking out the window, you're going to see someone who might have little interest and pleasure in doing things. They may look depressed to you. They may be sleeping a lot. They may have little energy, poor concentration. They may be short-tempered when they're trying to be given care. All of those issues are correctly captured on the MDS screening. Next slide, I'll tell you why. Okay, so I want you to keep important. These are all the sort of tips about the interview. The thing that I think is the most helpful, and this is so hard to do with a subacute person that you've got, the look back you said was 8 days, right? And you need to do it like by day 5-ish.
Well, day 3 is the...
Day 3 is the goal?
But you have till day 5.
Okay. So, to have built a therapeutic rapport with the patient to the degree that they're going to reveal accurately is tough in that short period of time, which may be a reason to redo it later on if you decide that it's necessary. This is when being a mental health professional does come in handy, because we're trained to establish that therapeutic, trusting, safe rapport very quickly. If you can build that strong rapport, then you're going to get a more accurate report. If you don't have that rapport, you may get a "I'm fine" kind of response. I'm fine, just write down I'm fine, I'm fine, I'm fine. And you can obviously see he's not fine. Very important to understand and follow all the MDS rules about this section. Next slide. Okay, this is perhaps the most important concept in my whole presentation, because it's where people make the errors most commonly. This is a direct quote. It's important to note that coding the presence of indicators in Section D does not automatically mean that the resident has a diagnosis of depression or other mood disorders. Assessors do not make or assign diagnoses in Section D. They simply record the presence or absence of specific indicators. You really are supposed to wear blinders when you do this, as far as what other diagnostic, information you might have on the person. You're just supposed to really look at whether these indicators are occurring. That statement is repeated both at the beginning of the interview section and at the beginning of the staff assessment section. Okay, so these are some of my getting started tips. They're pretty self-explanatory. It's what you think, like, hey, how about a quiet private place to do this? Use the person's hearing aid or get a hearing device. I love those whispers. And then there's the opportunity to refuse or decline. And this is really important. This is another error I see very commonly. People who are the assessors are driven to get this done. So when the person being interviewed says, I'm fine, I'm fine, I'm fine, even if they have other information that says, this resident isn't really giving me his voice. He's not trusting me enough to tell me the truth. He's just saying he's fine. They weren't given permission to refuse. So what they're doing is saying, I'm fine, as a way of refusing the interview. So if you give a resident the opportunity to refuse or decline, in that case, you'll get a more accurate data by going to the staff assessment. All things being equal, interviewing the patient always gives us better data. But if it's this kind of a situation where they're in essence refusing, it's better to go to the staff assessment. Another thing that I've seen in error is people have combined the BIMS and the MOVE section together and jump back and forth asking different questions for each one. Like one social worker told me, I start with the appetite question because it's the less threatening. It ruins the data. This is data collection. This is like research. So every item is read as written and it's read in order. It's really beneficial to take those items and print them out, one item per page in big letters in a little booklet and hand it to the patient and let them read the item as you're asking the question. Next.
You left off scheduling on Friday night.
Oh, yeah, well, that would be a good thing. Yeah, that would be.
You don't want to ask somebody if they're going to hurt yourself.
Especially the last question. Yes, exactly. Next one. Okay, so when you read the choices after every question, you're scoring the presence of the sign first and then the frequency. It's really important to give a cue card on that because these can get confusing. Some of those questions are complex and some of the answers are complex. What do you mean? More than half the time, less than half the time, 2 days, 1 day? So a cue card is helpful. Then there's a situation where the person is not giving you the voice. You know more about the patient that the patient is willing to disclose. I recommend sometimes going back to a clinical interview and then redoing the MDS from the beginning once you kind of have them reveal themselves to you in a less structured conversation. And people are not using, this is another common error, they're not using coding 9 often enough. If you can't score that answer, if you're guessing what the answer should be, what you should score, it's not scorable. Sarcasm, which happens a lot in New York, how's your appetite? Great, I ate all the lobster and filet mignon you served me last night. That's not a scorable answer, okay? So that's a 9. You get 3 9s and you go to the staff assessment. Next. So that's the cue card. If you just print up the answers on a cue card like that and hand it to the patient as you're asking the questions, it'll be easier then to tell you what their answer is.
I haven't seen people use that in a while.
It's really helpful, yeah. Much more accurate for patients. And here's the other sort of disclaimer with that. The goal is to record the resident's scorable responses as they are stated, regardless of whether the resident or the assessor attributes the symptom to something other than mood. Further evaluation of clinical relevance of reported symptoms should be explored by the diagnosing clinicians. In most nursing homes, that's doctors and nurse practitioners and PAs and us, the psychologists, which are PhDs and PsyDs. One of the things to kind of keep in mind with that is when you ask somebody, how tired are you, how often are you tired, well, I go to dialysis 3 times a week, you know, so I'm always tired then. And am I supposed to score that? Because he's not tired because he's depressed, he's tired because of dialysis. Yes, score it. It's irrelevant. The reason why the patient attributes it or the assessor attributes it. That's what that statement said. Capture it. Okay, these are techniques for interviewing. We're kind of going in deep here, but there are only these 4 approved interviewing techniques in the MDS. You're not supposed to go further afield than reading the question and using one of these interviewing techniques. My favorite one is to split those complex questions into 2 questions. You know, because there's one question that says, do you feel speeded up or do you feel slowed down? You can ask that as 2 questions. Do you feel speeded up? Find out what the scoreable answer is. Do you feel slowed down? Find out what the scoreable answer is. Whichever is the higher scorer is what you record. Okay, next. All right, so now we're to the fun part. The follow-up clinical assessment interview is really critical for care of the patient. So since we're just gathering data on possible mood disorders, we have to make sure we're going to be doing our clinical follow-ups. And that doesn't necessarily mean a care plan in every situation. When it comes to looking at the scores as a whole, it's recommended that if they score 5 or higher, and it's usually 10 that will trigger for reimbursement on like the, Joe, it's the split half, is it called? The end split of the clinical complex patients, for instance, in the long-term care. They don't get sort of counted toward the reimbursement till you hit a score of 10. Remember, the score can be as high as 27. If you're in a nursing home and 75% of your patients are scoring 2, somebody's not doing this correctly. The overall research in the field shows that depression runs about 20% in nursing home populations, although detecting it can sometimes run lower than that. But anybody with a score of 5 or greater maybe should have a follow-up about and see if something's going on, because they may be in the very early stages of something. If somebody has a severity of more than half the time to question B, which, as I recall, is the question that says, are you depressed? If they say yes, more than half the time, I feel depressed or down, then definitely get them an evaluation, even if that's the only question that they answer that way. Question F is the question that says, I feel bad about myself. I feel worthless. I've let my family down. If they feel that way more than half the time, I would also want a social worker, clinical person, psychologist to come and see if they needed a little psychological therapy, a little supportive therapy for what they're going through. And then, of course, the final question, which is the are you interested in harming yourself question, which Joe doesn't want you to ask on Friday night because he was traumatized by that happening when he was director of nursing.
Trying to get somebody help on a Friday night.
I know.
Can't you ask that question in the morning?
I've been called on Friday night by directors of nursing because of this. Okay, so if anybody says even a little bit that this is how they feel, then it may be worth having it further checked out by a mental health professional and have a full psychiatric or psychological assessment done. All right, next slide. Okay, so let's talk about the last question a little bit, the suicidal issue. People who are seriously ill often, and who have a lot of spiritual practice in their lives, a lot of faith belief in their life, may recognize that they're moving toward the end of their life, and that's fine. My own grandmother was like, you know, there's a party up in heaven, and when am I getting my invitation? You know, and she was 93, she was kind of done. So that's not suicidal. That's a passive wish to die. That's somebody saying, you know, I think I'd be better off dead than suffering in this way, because I believe when I die, I'm going to be in this wonderful place called heaven. That's not suicidal. Those folks are not going to harm themselves. But it is a passive wish to die, which means they're having trouble coping right now. And maybe someone coming, it's not an urgent referral, but go and see how they're doing, and have a psychologist to offer them some support, perhaps. Sometimes it's attention seeking. It's making suicidal gestures or statements to try and manipulate others. The danger with sort of catching on to somebody, sometimes borderline personalities are like this. They can be very dramatic. They threaten suicide to get attention. They threaten self-harm. You know, it's kind of the infantile, I'm going to hold my breath until you give me that candy, mommy. It's, you know, it's that kind of thing. But the problem is that occasionally they're successful. So people meant to make a gesture, a suicide gesture for the attention, and ended up something went wrong and they died. So we still have to pay attention to this behavior. Some people are what we think of as passively suicidal. It's the diabetic who is in imminent end-stage renal failure, mostly blind, has lost both feet, and is still eating every piece of cake, cookie, and candies he can get his hands on. People who are not in a nursing home who engage in very dangerous behavior. Might be someone who, you know, you're going to tightrope walk across the Empire State Building in Manhattan. That's dangerous behavior. So they may be sort of passively suicidal to think about doing that. Active suicidal is thinking, intending, and planning to harm himself in order to die. How much time do I have?
You're almost there.
Okay. Next slide. Is that it?
Yep.
Okay, so I think what I wanted to say the most about this issue is that when this comes up, on that last question, your first decision is it a passive wish to die or is it active suicidal behavior? The passive wishes to die, you don't need to call me in the middle of the night to come running. You do need to put in a consult request so that psychology sees the person at the next available opportunity, but it's not an emergency for someone who's just wishing they could get to the party in heaven. But for someone who is saying, I don't know how, I don't know when, I don't even know if I do it, but I think about it all the time, and I watch the nurse a lot because sometimes he walks away from the med cart. And I'm just thinking what I could do. Like if there's somebody sort of fantasizing about it, thinking about it, trying it on for size, that may be someone, or someone who tells you outright, yeah, I have a plan and I'm intending, you know, I'm just waiting for my chance, because it takes privacy, opportunity, and means and ability to carry out those means that makes you at risk. If you judge that somebody's in risk, then you need to ensure their immediate safety, and they need to be under a watchful eye until they can be fully, their lethality level can be fully evaluated. And whether that's a one-on-one or direct site observation in a group setting, or sending them out to the hospital, or you have psychiatry or psychology available immediately to come see them, you must respond to that. So, and then arrange the follow-up. So that's what I have to say. Ooh. Can I, do I have one more?
Sure.
Yeah, you have 15 minutes left for the webinar.
Okay, great. So we'll have a little bit of time for questions. Joe said I'd talk a little bit about the BIMs. I focused on the mood section in the slide, but I will sort of offer you kind of a tip with the BIMs, because it's another very common error that I see with the people giving the BIMs, and it results in a higher score, which doesn't help you with your reimbursement. And it has to do with the assessment of short-term memory. In the BIM suggests that you give someone 3 words to remember. And the 3 words are blue, sock, bed. And you give those 3 words, and the patient has to remember them. And then later on in the series of questions, you ask that patient, what were the 3 words I told you to remember? And we're supposed to be able to see if they can say blue, sock, bed. We don't score it, but it's also good to go a little beyond that if they don't quite remember and say, well, one was an article of clothing, or one was a color, or one was a piece of furniture. Do you remember? And if they don't, you can say, did I say red, pink, yellow, or blue? Did I say a chair, a desk, a table, a bed? You know, you can put it embedded in a list. The reason I suggest that, if you have time to do this, is because people with depression and who are cognitively intact score as badly as people with dementia on what were those 3 words. That's called free recall. No hints, no clue. Depressed people and dementia people score the same. And depressed people who have white hair and are in a nursing home and have a bad memory on that test may be mistaken for having a dementia sign instead of a depression sign. Once you give them a clue, like one was an article of furniture, oh yeah, you said bad, or you say, did I say table, chair, whatever, then, and they can pick it out of the lineup. By the time you get through that, what's called the cued recall question, or the final question where it's embedded in a list of possibilities, which is called the recognition trial. Once you get to that level, even depressed people who are cognitively intact will score at normal levels. So it distinguishes between people who are depressed versus demented, or people can be both, of course. So if they're demented and depressed, they will score badly, or if they're just demented, they'll score badly through all 3 trials. So that's one little hint about also looking for your depression in the BIMS. The second thing with the short-term memory, while we're on it, when the social worker who's responsible or whoever is responsible for giving the BIMS passes the resident in the hall and he says, oh, you're the blue sock on the bed lady. Stop using those words, please. You're no longer testing short-term memory. He's obviously encoded it into long-term memory. This may be less of an issue for the PDPM, but to the extent that you're going to repeat measures and people are going to recall these measures, change up the question. Any 3 words will do. It's good to have them in different categories. You can do, you know, a flower, form of transportation, and a kind of food. So long as they're in 3 different categories, you can pick 3 other words, and you should rotate them during the repeated measures. So those are my BIMS tips.
Okay. So it sounds like we have 10 minutes for some questions, right? Lauren, you want to maybe read us
So the only questions that came in, you guys will be receiving a recording of this webinar right after. So we will send that to you. So you will have the slides and what the commentary that Joe and Dr. Jean just spoke about. If anyone does have any questions at this time, please feel free to submit them in the bottom right-hand corner of your screen. I think we have a quiet audience today.
Well, that's always the sign of an effective presentation.
We did just want to remind you that
we answered all their questions.
Exactly. You guys were too thorough.
But if anyone does think of a question later on, if you email us, we'll be glad to respond and send you the answers. And also, go back to the prior slide. Don't forget we have the ICD-10 coding webinar coming up on September 19th, and anyone who registered for this conference can get a 50% off registration. What's the code word that you use?
The code word is bundle. Bundle.
B-U-N-D-L-E.
There will also be a registration link when we do send you the recording of the webinar. You can click that, or you can feel free to email marketing@grassicpas.com, and we can send you the registration link as well.
We're going to be sending that out again. Yeah.
Good. Okay. Well, thanks, everyone. Did you want to say anything else, Jim?
We have some other material that we can make available that I can send you the cue card. I can send it to you in Spanish if you're having a hard time getting a hold of it, or some of my other little tips. So, you know, let us know if you would like more information. I'd be happy to to communicate with people directly or share other additional handouts and materials. One thing we didn't mention, and since we have a second, I'm going to throw it in there, is it's really helpful to not just train who's doing the BIMs and doing the mood section, but to train all your staff. Because when we do the staff assessment, all the staff has to understand the language of the material, of the BIMs, of the mood section, so that when a person who's got to do the staff assessment says to a CNA, do you see poor concentration? You know, he's always like that. It's not like I see poor concentration. He's always been like that. That is poor concentration.
Right.
Yes, you're seeing poor concentration. You have to report it, even though it's not a change from how he always is. It's a stable characteristic. So training staff to observe so that it can help the staff assessment is important. And also training any of your other clinical staff who's going to be documenting in the chart in the language of the MDS is helpful as well, because when it shows up in recreation or it shows up in rehab, that they can identify it in the Section D language and report it as having observed it. And if it's a stable characteristic, like poor concentration, maybe they don't report it in every note, but periodically they mention it. And that way, if anybody ever wonders, gee, where did this information come from? Or are you, the assessor with the Section D, the only person that saw these signs? It gives you backup in your documentation. So this isn't just for the person who's doing the assessment. This is for the knowledge of the entire community of the nursing home.
You know, I just want to add too that, Jean and I work for two different companies. Grassi Healthcare Advisors is a healthcare consulting company, and we work a lot with skilled nursing facilities and other healthcare organizations. And Jean works with Psych Associates Group, which is a provider of psychology services in skilled nursing facilities. But she and I collaborate a lot on helping facilities look at their processes for accurately gathering this information and following up. So if anyone has questions or wants to talk to us about how you might be able to improve your process, either A, to get better data, or B, to make sure that when you do identify these issues, people are getting the care they need, feel free to email either of us, and we'll be glad to help you.
Mm-hmm. Absolutely. And I personally go and do the training in all the nursing homes where we consult, and do the training of all the different staff, and it's one of my fun things to do. So if you're out there, call me.
Okay. Thanks, Lauren, for facilitating.
Of course. Thank you all for joining, and hopefully we will speak to you guys all next week. Have a great day, everyone.